Good evening, class. Welcome to MUR 201, Diabetes Mellitus. I'm your instructor today, Gwendolyn Burnside, and we'll be talking about diabetes mellitus. And our goals for today is the learner will be able to discuss the two types of diabetes mellitus by the end of the lecture and be able to tell what's the difference in short-acting and long-acting insulin. The learner will be able to identify hypoglycemia and hyperglycemia and signs and symptoms and how to treat. And goal 3, the learner will be able to teach patients diabetic care of feet. Objectives for diabetes mellitus, the learner will be able to identify type 1 and type 2 diabetes by the end of the class. Objective 2, the learner will be able to acknowledge the difference in short-acting insulin of R and Novolog versus intermediate insulin and long-acting insulin by the end of the class. Objective 3, the learner will be able to assess for hypoglycemia and hyperglycemia. And objective 4, the learner will be able to demonstrate teaching strategies for diabetic foot care. And now you should have read your information in McCain, Herther, and Brasher 2014 edition in pathology and your med-search book concerning endocrinology. I'm going to hand you out a pretest for you to take very quick for me so I can kind of gauge your knowledge and your understanding of your assignment that you read this past week. Okay. Everyone's finished? Okay, now go with the answers. Question number 1. The best way to take care of your feet is to A, look at and wash them each day. B, massage them with alcohol each day. C, soak them for 1 hour each day. Or B, buy shoes a size larger than usual. The correct answer is A. Number 2, if you're beginning to have a low blood glucose reaction, you should A, exercise. B, lie down and rest. C, drink some juice. D, take rapid acting insulin. The answer is C, drink some juice, like orange juice, grape juice, or drink a Coke to bring your sugar up, bring the patient's sugar up. And number 3, numbness and tingling may be symptoms of A, kidney disease, B, nerve disease, C, eye disease, or D, liver disease. Numbness and tingling is an example of peripheral vascular disease, is an example of nerve disease. And now, what is diabetes mellitus? Diabetes mellitus is a disease in which the body's ability to produce or respond to hormone insulin is altered, which causes a malfunction in metabolism of carbohydrates and increased levels of glucose in the blood and urine. Okay. Type 1 diabetes. Type 1 diabetes, also known as insulin-dependent diabetes mellitus. Type 1 diabetes results from destruction of the beta cells, and which leads to the decline in insulin production and causes rampant glucose production by the liver. The overproduction of glucose production in the liver results in fasting hyperglycemia, which will be discussed later in the slide in the lecture. Glucose from food cannot be stored in the liver and stays in the bloodstream, which that's why you have your problem with diabetes. Next, you have kidneys. Kidneys cannot resorb the glucose once it meets its renal threshold, which causes glucose to appear in the urine, better known as glycosuria. Excessive loss of fluid from the body goes hand in hand with excessive excretion of glucose in the urine, leading to osmotic diuresis. So that's why diabetics like to urinate, because of the body and the threshold of the urine being in the body and sugar causing it to resorb, causing it to TT a little bit more. Fat is broken down into ketones, which is a direct product of Kidneys cannot reabsorb glucose once it meets its renal threshold, which causes glucose to appear in the urine, better known as glycosuria. Excessive loss of fluid from the body goes hand in hand with excessive excretion of glucose in the urine, leading to osmotic diuresis. So that's why diabetics urinate. The fat is broken down into ketones, which is a product of fat breakdown. Causes of type 1 diabetes is genetics. Genetic plays a role in destruction of beta cells in type 1 diabetes. And environment. The most common form of diabetes in children under the age of 12. It's most common in children under the age of 12. Stop. Let me do that. The most common form of diabetes in children is from diabetes. Causes of type 1 diabetes is genetics. Genetics plays a role in the destruction of the beta cells in type 1 diabetes. And environment. Environment exposed to a virus can result in damage to beta cells, bringing on type 1 diabetes. And this is the most common form of diabetes in children under the age of 12. Clinical manifestations of type 1 diabetes. We're going to see polydysnia, polyuria, polyphagia. You also see weight loss and fatigue. When I say polydysnia, I'm saying increased thirst, polyuria is increased urination, and polyphagia is increased hunger. And you usually see that in type 1 diabetes. Type 2 diabetes is caused by impaired insulin secretion or insulin resistance. Insulin cannot bind with the special receptors, so insulin becomes less effective at the stimulating uptake of glucose and regulating the glucose release. There must be increased amounts of insulin to maintain glucose levels at a normal or slightly elevated level. There's enough insulin to prevent the breakdown of fat and production of ketones, and it leads to uncontrolled type 2 diabetes. And type 2 diabetes is better known as non-insulin dependent diabetes mellitus. And it's usually seen in the ages of 64 to 67-year-olds. Causes of type 2 diabetes mellitus, you see excessive weight gain or obesity causing insulin resistance. You see inactivity, sedentary lifestyle, which is basically no exercise, resulting in insulin resistance and impaired insulin secretion. And also other risk factors you may see: age, obesity, hypertension, and family history also are precursor for diabetes mellitus. Clinical manifestations of type 2 diabetes, they usually are overweight, they have dyslipidemia, hyperinsulinemia, hypertensive, which we were saying earlier, which is a risk factor. You'll see polyuria, polydysnia, polyphagia, which is increased urination, increased thirst, polyphagia, which is increased hunger. You'll see fatigue, pruritus, which is itching, recurrent infections, visual changes, paresthesia, and weakness. Signs and symptoms of hypoglycemia, you'll see sweating, tachycardia, hunger, restlessness, and you'll see anxiety, tremors, fatigue, irritability, headaches, loss of concentration, visual disturbances, dizziness, convulsions, coma, and death. Signs and symptoms of hyperglycemia. In hyperglycemia, you usually see polyuria, polydysnia, polyphagia, fatigue and weakness, which is feeling tired and sleepy, and vision changes. And usually with hyperglycemia, we're going to treat that with a rapid-acting insulin. And with the hypoglycemia that we said earlier, you're going to treat low blood sugar, which is hypoglycemic, with giving them juice or feeding them their meal, trying to get their blood sugars up that way. But in hyperglycemia, we're going to give them something to take the blood sugar down. And that's where we're going to go into rapid-acting insulin. In rapid-acting insulin, it begins to work at 15 minutes after injection. Its peak time is an hour, and it continues to work for 2 to 4 hours. An example is Humalog, and aspartame is been known as Novolog. Your next insulin is a short-acting insulin. A short-acting insulin is better known as regular insulin. It reaches the bloodstream in 30 minutes after injection. Its peak time is 2 to 3 hours after injection, and it works for approximately 3 to 6 hours. An example is Humulin R and Novolin. We're going to use that Humulin R to get that blood sugar down, which is a short-acting insulin. Your intermediate insulin is better known. It reaches bloodstream in 2 to 4 hours after injection. Its peak time is 4 to 12 hours late after injection, and it's effective for 12 to 18 hours. An example of this is Humulin N, Novolin N. Those are your long-acting. This is your maintenance insulin. This is what you take every day routinely. Usually you see diabetics take it in the morning. They'll take maybe 10 units or how many the doctor prescribed for them, and that's their maintenance dose of insulin. And next you have long-acting insulin, which reaches the bloodstream several hours after injection. It tends to lower the blood glucose levels. It's fairly over a 24-hour period. Examples is Levemir and Lantus, which is known as Gargan and Detamir. Lantus usually is given at night, so you always have to watch your patients, especially in nursing homes at night when you're giving that Lantus. You want to make sure they eat a snack. You also want to make sure that you check them frequently because they will drop on you at night. This long-acting is, so that's your on that. Okay. And patient teaching, what we're going to teach our patients, that about foot care. It's better when you teach your diabetic about foot care because it's important, because that's how they lose their limbs if they do not take care of their feet. You want to check your feet every day. You want to look at your feet for cuts, blisters, red spots, and swelling. You want to use a mirror to check the bottom of your feet or ask a family member to help you if you have trouble seeing your feet. You want to wash your feet every day. You want to wash your feet in warm water, not hot water, every day. You want to dry your feet thoroughly and in between the toes to decrease the risk of breakdown of your feet. You want to make sure that you want to keep the skin smooth. Rub a thin coat of lotion over your feet and the bottom of your feet, and it helps them to stay nice and moist and not crack. And also, number 4, you want to make sure you smooth corns and calluses gently. Some doctors recommend that they can use pumice stones, but I do not recommend that. I think you need to talk to your podiatrist before you start to use pumice stones on your corns. And also, if they have any corns or calluses, you want to refer them to a podiatrist. If you can't see, reach, or feel your feet, you want to trim your toenails regularly. You want to trim them and cut them straight across, and you want to file them straight across. You do not want to curve them or anything. And if you can't see your feet to cut your toenails, or your toenails are brittle, brown and yellow and breaking down, you want to let the podiatrist trim your toenails, especially if you have ingrown toenails. You want to let them, you want to tell your patients to let the podiatrist trim their nails. You also want to teach your diabetics to wear shoes and socks at all times. Usually you want to teach them to wear white socks so they can tell if they're bleeding. If they live by themselves, they can't really tell if their feet have sores on them. You want to tell them never walk barefooted outside or inside their house. Always wear shoes that fit well and protect your feet. Don't wear shoes too large or too tight. Those will make sores on their feet. You want to feel inside your shoes before putting them on to make sure that the lining is smooth and there are no objects inside that could puncture their feet. So you want to tell them to do all those. And now we're going to do a case study on diabetes. We'll talk about that and discuss it. Pass that around for me, sir, please. Pass that around, sir. Okay, this case study is about a patient, a 56-year-old male who has type 2 diabetes. He was first diagnosed with the disease at 12 years old. He has come to see his primary care provider because for the past 6 weeks he's had numbness and tingling in both feet and extending from the tips of the toes just below the ankle. For the first 4 weeks, these sensations were intermittent, but now they're constant. He stated he also has occasional episodes of substernal chest pain, and these are brief and occur both at rest and when he's active. The patient is 5'6", he weighs 267, his BMI is 43.1, placing him in the category of obese. He is currently prescribed metformin 800 twice daily, hydrochlorothiazide 25 twice daily, lisinopril 5 once daily. He has been prescribed postprandial insulin that stopped taking it 8 months ago because he felt it felt fine without it. So he thought he felt fine, so he just stopped taking his medicines, okay? His blood pressure today is 168/92. Aside from subjective complaints of numbness and tingling in both feet and chest pain and physical examination, the health history are unremarkable. The patient smokes 10 to 15 cigarettes a day and does not drink alcohol, and he has a desk job. When asked, the patient is unable to name any long-term complication of diabetes. Although he knows that a high serum glucose is not good, he does not know why. He has not spoken in depth about his disease with a healthcare professional for several years and he last saw his PCC 14 months ago. So he hasn't seen his provider for 14 months, people. The patient cannot remember when the last he had an eye exam in the past several years, and he confesses that he's never examined his feet and does not take physical precautions to protect them. He occasionally skips his metformin doses and antihypertensive. He never exercises, and he measures his blood sugars 2 to 3 times a month. Although his primary care provider has offered a patient consultation with a dietitian, a physical therapist for exercise program, an appointment with a smoking cessation program, the name and address of diabetes support group, the patient has not followed up any of these providers. The patient is married, and according to his patient, his wife thinks he looks fine, and he does not understand why, if the patient is relatively happy with his current state of health, he needs to take all those medications. When he came into the office, he was going to A1C was 9.4, his blood glucose level was 219, serum cholesterol was 199, his bone was 24, and his creatinine was 1.9, and his renal function was 56.6. His 12 EKG lead showed mild degree of left ventricular hypertrophy. In this patient, as we see in this patient, he's a risk factor because of his obesity. He's in a risk factor for having diabetic complications. Because his renal function is high, he's at risk for end-stage renal disease, and also because he's a hypertensive, which is a risk factor, putting him at end-stage renal disease. Also, with the elevated blood pressures, and the elevated blood glucose levels, he had a risk for peripheral vascular disease, which is the small and large vessels being damaged, resulting in him having foot ulcers, making him possibly lose a limb later on. Because he also has a desk job and he's sedentary, like we said earlier, not moving around, puts him at risk for having diabetic complications. So anybody have any questions concerning this case study? So how can we help this 6-year-old? We want to tell him to do what? We want to tell him to check his blood sugars 3 times a day and not 3 times a month. We want to put him on a regular exercise program, and also bring his wife in to do an exercise program with them. Also encourage her to cook diabetic meals, so 1,800 calorie ADA diet maybe, and to basically to help control his meals. And bringing her on board will help him be more compliant, probably. So you want to include the family in the teaching also in this process and getting her in on this. Y'all have any more questions? All right, thank you. Y'all have a good day. I'll see you tomorrow.